Well, good afternoon. My name is Stephanie Swerzik. I'm an independent insurance agent and owner of Simplified Financial Solutions. I want to welcome you all to our third webinar in a series of discussions centered around Medicare, Medicaid, or both. If this is your first time joining us, thanks for joining. I did want to just reiterate, in case somebody joined late, what Bev Ann said, that the first two webinars are available for replay. They're on YouTube, and the links will be sent out after our meeting. Our first discussion was centered around kind of the basics of Medicare and the Medicaid program, so just kind of the basics. At our most recent session, we talked about options during open enrollment and annual enrollment, Medicaid expansion in Nebraska, and what you should know when choosing a managed care organization administering the Medicaid benefits, and then how to best choose a Medicare plan. Today, we will hear from our panel of experts to include Vicki McHugh with Key Complete Therapies, David Thompson and Steve Schmidt, attorneys at law at Carlson Burnett. And I want to welcome our guest speaker, Lora Young, who's the director of the Center for Independent Living with the League of Human Dignity. They'll talk about why the waiver programs were developed and a deeper dive into the aged and disabled Medicaid waiver, the referral process, what qualifications you must meet, and then services available. As you listen in, I just want to encourage you, if you have any questions, to please throw them out there in the chat. And then before I turn things over to Vicki, I just wanted again to extend a heartfelt thank you to Bev Ann Phillips for helping us to stay organized, on topic, and keep these seminars successful. We quickly realized when we had a recent meeting that we couldn't do it without her. So thanks again to Bev Ann. And Vicki, I'll turn it over to you.
Very good. Well, thank you so much. I'm thrilled to see, like I mentioned, the number of additional and new participants in this webinar, and hope that you start to gain a little bit of information. We recognize that we're only going to be scraping the surface, but hope to let this launch into some additional conversations as well as additional resources moving forward. As a review of the basics, we just wanted to make sure starting as a ground level, that Medicaid waivers and eligibility have nothing to do with Medicare or Medicare eligibility. So just kind of making sure that we all have that as a starting point. To be eligible for any of the Medicaid waivers, you first and foremost must meet eligibility for Medicaid requirements. And that was addressed a little bit in our previous seminars also. So take a look at those if you didn't have the opportunity to listen live with them. Overall, there are several waiver programs within the Nebraska Medicaid system, and today our main focus is going to be looking at the Nebraska Aged and Disabled Community Waiver. And so keep in mind as we're moving through this that this will be just addressing this one waiver program, and we will be covering others and trying to identify additional answers moving forward with our continued seminar series. Next, we are going to hear from David about the arching aspects of the waiver program and the background.
Okay, everybody. Well, I'm David Thompson. I'm an attorney at Carlson Burnett. I want to add to what Stephanie and Vicki said, our thanks for all of you for attending this panel discussion. It's the third in an ongoing series. We'll see how far it goes into the future. But for now, I'm going to talk a little bit about the background of the Medicaid waiver. It helps me sometimes to think about things historically, like where did we get this word waiver and why is that the terminology that we use? And so I thought it would be helpful just to sort of give you a little bit of background. I'm not going to spend too much time on my presentation because Lora Young is really the person we're here to see. So when we talk about the Medicaid waiver, often people go all the way back to the Omnibus Reconciliation Act of 1981. And that was a piece of federal legislation that for the first time actually used the language about waiver and home community-based services. But really you can go all the way back to, frankly, you can go all the way back to Franklin Delano Roosevelt And you can see how the dialogue conversation sort of progressed to, we got to have health insurance, or we got to have financial supports for everybody. We got to have financial supports for children. We got to have financial reports for the disabled. It kind of evolved over time, partly because the government had to narrow the number of categories that were actually going to receive funding, because as you know, that's an issue. And so in addition to talking about what happened in 1981 and what changed, it's important to keep in the background two really important factors here. And one is the Americans with Disabilities Act, which was passed in 1990. And the other was a really interesting Supreme Court case called Olmstead versus LC, which has turned out to have a lot of impact. And I'll just say a little bit about that case when we get to it. So one of the things that I always ask is, well, what's the waiver do? What's it for? What are the problems that it's designed to solve? And it's worthwhile remembering that, and this is probably, maybe this is clear since it came from a budget bill, but the Medicaid waiver was intentionally intended to be a cost-saving measure. Basically, Medicaid just realized that they were spending too much money keeping everyone in nursing homes, so they decided to, open it up to explore alternatives to that. And so one of the things they came up with is the idea of a waiver. And what a waiver really is an exemption from the Medicaid rules. And what those rules generally are for is to define how funding is provided to nursing homes. That's the general rule of Medicaid. And so you can see then that by granting certain organization an exemption from these Medicaid rules, it made it possible for people and organizations to offer all kinds of different services, much more individualized. If you go through and read the Medicaid regulations, they're actually extremely complicated in terms of how it's supposed to be administered, how it's supposed to be paid for, how, and there's all these rules about how different parts of the state have to do it exactly the same way. It just goes on and on and on. Whereas the waiver thing is, it basically says, we're not going to spell out the details. Each waiver program has to sort of come up with its own plan. And in the case of the waiver, we're going to be much more focused on the individual as opposed to on the institution. So you'll hear this term a lot. It's called person-centered planning. And it's easy to see when you read the regulations why they would use that term, because as I said, the Medicaid regulations as a whole are much more about institutions and finances and administration, whereas waiver is really about getting to know a specific individual in a specific situation and figuring out exactly what kinds of services are going to enable that person to live as well as they possibly can. So here's where the language comes from. The Secretary of Health and Human Services may, by waiver, provide that a state plan may include as medical assistance under such plan home or community-based services which are provided pursuant to a written plan of care to individuals with respect to whom there has been a determination that but for such services, the individuals will require the level of care provided in a hospital or nursing facility. So lawyers love the phrase but for, we use it a lot. And I think by showing you the whole passage here, it makes it clear that, what we're basically saying is that if the waiver program didn't exist and somebody had to be institutionalized because of that, well, what is it that the waiver allows us to do otherwise? And and this is the term home and community-based services again. And I think it's helpful when you're trying to remember what the word waiver refers to just sort of think of that language. And if you want to read the Social Security Act for fun, I'd recommend that too. So that was the national version of the waiver that I was talking about. Let's talk about Nebraska's version of the waiver. Actually, Nebraska's version of the waiver, which you can find in the Nebraska Administrative Code, that's what NAC means at the bottom of that slide. So basically it says the same thing, that you have to have needs that ordinarily would qualify you for nursing home care. But if we can identify certain services, we can basically keep you out of an institution. And that's extremely important for all sorts of different reasons. But I think, I think it's, everyone can agree that, providing someone with the supports they need to live in the community is just a really great thing. And in addition to the Medicaid waiver, I think it's important to look at this famous Supreme Court case called Olmstead versus LC. And that case really established a framework that you're going to hear over and over when you're researching in this area. So if you just go to Google and you type in Nebraska Olmstead Plan, it's going to give you all these sets of different documents that have been worked out over years of planning. There's conversations about planning, and there's plans about conversations about planning, and it just goes on and on and on. But we're at an interesting point right now in the sense that we are actually in year one of the implementation of the Olmstead Plan that was developed by the state of Nebraska. After the Olmstead case happened in 1999, there were some laws passed that basically required every state to develop its own Olmstead Plan. And we've been working on that in Nebraska for about 4 or 5 years now. And as I said, we're at an interesting time right now because we're actually in the first year where the plan is going to be implemented. So the case that it comes from, Olmstead versus LC, LC refers to a woman named Lois Curtis, who had been diagnosed with schizophrenia and admitted to a psychiatric hospital in 1992. And a year later, she was pretty stabilized and was on meds and had recovered much of her functionality. But they kept her in the facility for another 4 years. And as a result, she, with the assistance of some lawyers, filed a lawsuit claiming that this was not fair to force someone like her to, live in a facility when they had already basically been stabilized. And if you read the documents around the case, again, this question of money comes up. And so what the facility said is basically, they didn't have enough money to develop any kind of complicated programs about services that are out there beyond institutions. It was hard enough for them to keep the institutions going. So that's what they were going to stick with. And as a result, people like Lois ended up staying in facilities much longer than they have to. Under the Obama administration, there was actually an Olmstead enforcement section created within the Department of Justice Civil Rights Division. So here's what the Olmstead case decided. Actually, wait a second here. I wanted to say a little bit about this actually, that the Olmstead case is really, for the world of disabilities, a lot like Brown versus Board of Education was for issues of race. Brown versus Board of Education established that separate facilities for African Americans and for whites were inherently unequal, and it demanded that there be integration. And really that you can see the Olmstead case as aiming for the same thing, the idea of integrating people into the community, not keeping them locked up in facilities. A really interesting case if you ever want to read it. So here's what the Olmstead case decided. And Ruth Bader Ginsburg wrote the opinion. So this is just yet another reason for being sad that she's not with us anymore. But the quote from the case is that institutional placement of persons who can handle and benefit from community settings perpetuates unwarranted assumptions that persons so isolated are incapable or unworthy of participating in community life. Confinement in an institution severely diminishes the everyday life activities of individuals, including relations, social contacts, work options, economic independence, educational advancement, and cultural enrichment. And I think that's a really powerful statement in terms of, it really addresses all the different aspects of our lives and what makes our lives fulfilling, and how, people with disabilities are entitled to the very same things that the rest of us are. So here's a little bit about Nebraska's Olmstead Plan. As I said, it really goes back 5 or 6 years to 2014. And as I said, there's been a really long process. December 2018, the strategic plan was delivered to the legislature. And this plan really outlines 7 different areas. And within these 7 different areas, there's like 10 different strategies and 5 different goals and all that. But basically, just to kind of simplify things, it's important to focus on the 7 goals of the plan. So one of the goals was, being more exhaustive and complete in terms of developing services. So again, this involves talking with a lot of people, bringing in a lot of case coordinators to understand what people need. And then if you go to the DHHS website, you'll see now that there's all different kinds of waiver programs offering all different kinds of services. And so the Olmstead plan is actually kind of similar to that. And as I said, the 7 different goals are, the services to be provided, supportive housing, decreased admissions to facilities, that comes straight out of the Olmstead case, educational opportunities, available transportation, employment opportunities in terms of providing pathways for people to get the training that they need to actually have a job that they're capable of performing. And then on the other side of that is one of the goals is for a high quality workforce. And what that basically is that all of the caregivers and all of the service providers under these waiver programs, we need to make sure that they are the highest quality people that we can find. And if we need to pay them more, we'll do that. And if we need to hire more, we'll do that. And so that's actually just as important in terms of defining what the provider's role is, as opposed to what the people with disabled role is. And again, we have this term, person-centered planning, and I pretty much defined what that was. And as I said, we're actually in year 1 of the implementation of the Olmstead plan. So that was my quick introduction. I mean, I think that, just understanding where this idea of a waiver comes from, understanding the kind of holdings and rules that came about as a result of the Olmstead decision. And with that, I'm going to turn it over to Lora, who has been working in programs related to waivers program, I think going back, Lora, to at least 1994. So hopefully you can provide us some insights into the Medicaid waiver. So I'll let you take it over. Thanks.
Perfect. Thank you, David. That was a great introduction in talking about waiver. So I'm going to specifically talk to you a little bit about the league, our role in waiver, and really the kind of the nitty-gritty on what happens to get somebody in the beginning steps of being qualified for AD waiver. I've been with the league for now 2.5 years. I have 2 distinct careers, one in chambers and of commerce and one in human services. I'm ending my career life in human services, so it's nice to be back. And I do want to recognize a couple people that I know on the call that I recognize your name. So hi, Megan, and hi, Matt. Waiver, what is it? And I need to move you all out of my way. Really, as stated before, it's to help people that are elderly or younger that are officially disabled. This wording is coming straight from the Nebraska website. Our goal is to keeping individuals at home or at the very least in an assisted living facility. And we look for ways to meet their needs with financial assistance for assistive technology. That could be home modifications. If you need help getting, if you need a roll-in shower, or if you need a ramp to your homes, with adult daycare, with chore, with nutrition services, with a PERS, which is an emergency button, to pay for that, for respite and transition services. As David said, you must qualify for Medicaid. We take approximately 80 calls a month with the league, because they want our services, they want to be on waiver, and a good portion of those individuals have not qualified yet for Medicaid. So we have to have them start with that process. Quickly, the income guideline for 2020 is less than $1,063 a month. And then they also look at your other assets. And as David said, you also must qualify for a nursing facility level of care. The League of Human Dignity, we contract with the state of Nebraska to provide service coordination for AD waiver. We work with people ages 18 and up. When I started 2.5 years ago, our age group was 18 to 65. And then we really looked at, and the state really said, we're doing person-centered planning and we're giving people a choice. So we will accept anybody 18 and up. Enowa, Eastern Nebraska Office on Aging, they do the same thing we do. They only accept people 65 and up. But we used to have to transfer our 65 individuals, but now they can choose to stay with us, or they can choose to go to Enowa. We have statewide offices or home offices in Lincoln, Omaha, Norfolk, Kearney, North Platte, and Scottsbluff. My office, we just stick with Douglas and Sarpy County, and we are currently sitting at about 695 consumers in our office. When I started, we were at about 450. So we have grown exponentially over the last couple of years. The referral process for our office really takes about 30 minutes. And I always, when I do referrals, which I do sometimes, I tell people I need 30 minutes of your time, because I don't want to rush anything. And I want people to understand that this is not a, hey, I want to do it, here's my information, goodbye kind of process. We get demographics. We confirm they have the right Medicaid budget. It's for AD waiver, you have to have Medicaid first, but you have to have a Medicaid budget that's AABD and non-Magi. And I'm not a Medicaid specialist. I don't know all of the terms, what all they mean, other than non-Magi is non-adjusted gross income. And we don't do any of that. So I can't explain any of that to you other than we look to make sure they have the right budget. If they don't, we can help them contact Medicaid, or they need to contact Medicaid to see if they qualify for the budget that we need. We do a quick needs assessment, which I'm going to go over with you, because that's what most people seem to not understand, is this process involves several levels of assessing. And once we complete our needs assessment, then we send it to our level of care specialist, and they're the ones who make the final, well, they make the first of two decisions on whether or not somebody actually qualifies for waiver. So I'm going to talk to you about the level of care. The level of care is determined by your limitations in the areas of bathing, dressing and grooming, eating, mobility, continence, and toileting. So when you see limitations in 3 or more ADLs, that's what we're talking about, are those areas. Can you bathe on your own? Can you get to the bathroom? If you can get to the bathroom, can you get in and out of a shower or tub without any help? When you get in the shub, can you adjust the water temperature? Can you put soap on a washcloth, and wash your entire body? We get real specific. We ask really specific questions. Can you get dressed on your own? Do you need help with any part of dressing? Maybe somebody can, dress in a shirt, but they can't get their pants on. That's a limitation. So we ask very specific, how much help do you need dressing? Can you put shoes and socks is a big question. Can you put your shoes and socks on? So those are some of the things we look at. We look at risk factors. Risk factors are a little harder, because there truly has to be a documented risk. A documented risk could be somebody has dementia and They walk outside their front door and they go half a block one way and they're lost. That's a risk. Somebody forgets that they've turned their stove on. That's a risk. So we look at a lot of those things, and a lot of those risks then are also medical. We look at cognition. How's your memory? How good are you at remembering your meds? We look at medical treatment observation. Can you take your meds on your own? Do you know why you're taking your meds? Do you know what meds you're taking? Do you know what time to take your meds? We look at all of those kinds of factors. So you have to have a combination of those to even begin the process to qualify. All of these activities of daily living must be daily except for bathing. Eating is not, we do not consider if you can fix a meal or if you can go to the grocery store at this process. Eating to us is, can you physically get food or drink from a plate or a container to your mouth to take it in? At this point, that's what eating is about. Mobility. How well do you get around? Let's say somebody uses a power chair and they can get around perfectly fine in their power chair. We're going to score that as 0. They don't need any assistance with that because they're independent. So basically, we're looking for independence. We look at continence and toileting and transferring. Now, if somebody is very capable of getting from their bed because they're using a transfer pole into their power chair and doesn't need help, anybody's help transferring, they're independent. But if you need assistance getting in and out of bed, on and off the toilet, on and off certain types of furniture, we're going to look at that and score that as having having need of assistance. Again, risk factors must cause a significant and immediate impact on a person's ability. They have to require an intervention. Behaviors are on here, but that does not mean physical behaviors. AD waiver, if you have a chemical restraint or need the use of mechanical restraints, you're not going to qualify for AD waiver. We don't do that. That has to be a whole other program. We look at frailty. How serious is your health? And we look at safety. And I gave some of those examples. The criteria for medical treatment and observation. A medical condition is present that requires observation and assessment. Complexity of several disabilities or several health issues and ongoing medical and nursing services. So we're looking at people with diabetes. Can you check your blood sugar? Can you give yourself an insulin shot if needed? Can you take your meds okay? We're looking at individuals that may have to be transferred, to and from a dialysis center several days a week. What kind of medical conditions are present? One of the things when I first started, one of the conditions that was debated a lot within my office was, I'm going to use asthma. And because I also have asthma, I used myself as an example. Just for the fact that I have asthma doesn't mean I can't bathe on my own, doesn't mean I can't dress on my own, doesn't mean I can't take care of my daily living skills. So we can't always just look at the medical condition. It's what medical condition do you have that's limiting your ability to take care of yourself with your ADLs. That's what we're looking for. We're also looking at things for ongoing medical and nursing services. However, AD waiver does not, if you need to have an RN or an LPN come in daily, weekly to do those cares, AD waiver will not pay for that. That goes back to your medical provider having to pay for that. But if you have a routine care that can be taught by a non-medical person, then that's considered chore and AD waiver will pay for that. So a lot of it is, changing sterile dressing, routine cath care, respiratory therapy. Oxygen is not included in respiratory therapy. Making sure people get adequate nutrition and hydration. And for that, you have to have clinical evidence. Therapeutic exercise and positioning, routine colostomy or alostomy care, skin care, and dialysis. Other things are wound care, medication monitoring. And again, the use of physical or chemical restraints are not allowed in AD waiver at all. Now, we've had some children as they're becoming adults that have always had a certain type of bed that, keeps them contained within their bed. Some of that is allowed, but it has to be really documented for the safety of that child. But that's really about the only kind of restraints that I've seen allowed through the AD waiver. And there we have to get special permission from home community-based services. Cognition is memory, the ability to remember the past and present events. Are you oriented to person, place, and time? Communication, your ability to communicate. Hard of hearing does not count. English as a second language does not count. So we're really looking for, if there's some question on cognition, we do a SLUMS score, a SLUMS test. And it's basically, it's a simple, basically a one-sheet test and having somebody draw a clock. And then you tell them to draw like 11:15, and they have to put the hands in the right position, and they have to draw the clock, the face of a clock correctly. You give them a set of words, and then you go on and do some more testing, and you come back and say, now, a little bit ago, I told you 4 words. What were they? So basically, we're doing a SLUMS test. Finishing up the level of care. After we get all of that initial information gathered, and it goes off to our level of care specialist, they will in turn, and unfortunately, we can't do anything in person, we'll call the individual back, ask them the same set of questions we've already asked to get more detail. Then each section is scored from a 0 to a 4. A 0 means you're independent. A 1 means you need a little cueing, you need a little, reminders. 2 means you can do some things on your own, but you also need help with some things. 3 is individuals that are pretty much need 100% full care. And if somebody is scoring a 4, they're probably not going to be in waiver, because a 4 means you need 2 people to do everything for you. And waiver is only going to pay for 1 caregiver. And with those individuals that are scoring a 3 that need everything done for them, they have to have a paid caregiver and an informal support. One of the key tools that we use is medical documentation. So it's not just enough for me to walk in and say, I have a bad back and I can't bend over to wash my lower extremities and I can't get in the shower by myself. We have to have the medical documentation to back that up. So if you're working with individuals that you're trying to get qualified for waiver, the medical documentation, and a lot of times it gets held up in our level of care office because we're not getting the right medical documentation. And when I talk about medical documentation, it's just not a letter from a doctor that says this person is disabled. Here you go. We want to see what the medical records say about this person. We do try to get people that come in here with just this letter from a doctor or a checklist. They need this, 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 and this, and this. And that's not true medical documentation. Medical documentation is all the treatments that a physician is providing for the care of an individual, to help them with their quality of life. So it's more than just medications. It's if somebody is complaining that they have back problems, then we're going to want to see documentation of what kind of back problems do you have. Have you had surgery? How have you had, lots of issues? So that medical documentation is one of our key pieces, especially now with COVID, when we cannot go out into the person's home and do the assessments in person. Then the determination is made if they're going to meet level of care. When that determination is made from our level of care department, then that level of care and all that medical documentation is sent back to our office here in Omaha, and we assign a service coordinator. The service coordinator goes out and completes a whole other set of assessments to really determine how much help somebody needs in their home. If a service coordinator goes out to the home, and even on the phone calls that we have now, they have to confirm that everything that we know in the LOC is correct. And then the service coordinator does their assessments. They do, it used to be called a time tool. It's now changed to something else, but it's basically that. Let's say I need help with bathing, dressing, and grooming. I can eat okay, but I can't cook. This is where cooking comes in. I can eat just fine, but I don't have the physical stamina to cook. Okay, so we're going to build in time to have somebody cook me 3 meals a day. I need help taking my trash out. I need help cleaning my house. That's where we come to deciding how many hours somebody gets. Somebody may have a lot of hours. Sometimes they have just a few hours a week. Totally depends on the individual. When all that is done and the consumer agrees to the services, they choose a provider. We get all the signatures we need for all the forms that we need. We create a service authorization and services can begin. Time frame, it can take up to 6 weeks, unfortunately. So we have a lot of people thinking they can call us and then get services started tomorrow. That's not going to happen. One of the things that makes that process longer is not getting all the medical documentations that we need. And really, that's in a very short time period, and I want to answer questions. That is what we do. And why it sounds simple, it really isn't. And I know there's got to be a lot of questions, and there's a lot of information in a very short period of time.
Yeah, if you have a question, go ahead and ask it. There was one in the chat, Laura, if you want to look at that one.
How does someone become a candidate for waiver services? Who decides when they should be an assessment to determine they qualify? Everybody has the right to have an assessment. So if you think you qualify, you can call us and we will do an assessment. But I'm going to go back to make sure that you qualify for Medicaid first. But if you think you qualify for waiver, if you need help in your home, or you think you know somebody that needs assistance, absolutely give us a call. We'll do a referral and send it through the process.
So I think there's another one in the chat. If you want to get that one, if anybody has a question, you can unmute yourself and go ahead and ask it.
The next question in chat is, how often is the person eligible for waiver reevaluation? We've discussed that a lot here at the league. And we're saying every 6 months, but you have to have something significant has to happen within those 6 months. If you're denied services, you can always appeal. They will send you a letter and tell you how to appeal with a form to appeal. And that goes in front of an adjudicator through Department of Health and Human Services. One of the other big questions that we're looking at, and we're getting a lot of referrals for people.
Go ahead.
We're getting a lot of referrals for people with the new expanded Medicaid budget. Some of those people qualify, some of those people do not. And so right now our process is to take those referrals, send them to our contacts at Home and Community-Based Waiver, and they have to go in to decide if they are truly disabled before we qualify. They're trying to figure out a better way for this yet, but right now it's a cumbersome process.
So how about a family member? Can a family member be paid to provide care?
They can. We have just gone to electronic visit verification. So if a family member wants to be that paid care provider, we are encouraging them to go with an agency. It goes a lot quicker. If they're going to try to do it on their own, it takes anywhere between 6 weeks and 6 months to get approved. You have to have a background check. They screen you for felonies. They screen you for any APS, CPS. You have to provide fingerprints, and that process can be long and daunting. But yes.
So I know Megan Wall is on here. This is as much for her as for you, Laura. But she does assistive technology. You mentioned that earlier, and I'm just kind of wondering, Megan, I don't know if you have any, quickly, if you have any illustration.
Under the A&D waiver specifically, whether it's through the schools or through Voc Rehab or, service coordination, there is a pathway and often funding that Lora can probably speak a little bit more intelligibly about, but the services will come in one way, shape, or form, whether it's home modification or assistive technology through the Assistive Technology Partnership in Lincoln. If the individual is on the DD waiver, which I know wasn't part of this conversation, there are some other different pathways through assessment and recommendations that are included in some of the funding. Knowing what you're eligible for. UCP of Nebraska has a grant, client assistance grant, that individuals that meet the requirements can request assistive technology and services in some ways up to $1,000 every 12 months.
Cool. Laura, I don't know if you want anything.
Well, I was going to say quickly for our side, if you're qualified and if you're on our caseload and you need equipment or if you need home modifications, there is a path to help that as long as there's funding through the state. So it's one of the things we do. I see there's a couple other questions. Are there cases where someone who was already in the facility assessed and determined to qualify? If so, does that mean they can move out of the facility? Yes, one of our goals is to keep people out of facilities. So if you have somebody that's, has been in it, gone to the hospital and gone to the nursing facility for rehab, but when they come home, they're going to need assistance. Absolutely. it's the same process. Give us a call and we'll do a level of care. And so we can have those supports ready when they come home. And I'm not sure if the next question is, how are home health agencies referred? I'm not quite sure what you're asking.
I'm sorry, that was my question. My name's Adriana from ACOS. My question is, do you give, once they qualify, do you give them a list of agencies to pick from, or how is that?
Yes, we do. We have a list, and right now it has about 90 people on it, 90 names on it. And because we do not choose one provider over another provider, we give everybody the entire list. We encourage our consumers to call providers, interview providers, because it's their choice. And we also have helped and encouraged consumers, if they're not happy with the care they're getting, they can request a new agency. They can change. So we give them unfortunately, it's a very long piece of paper and it's all done in alphabetical order. We're as non-biased as we can absolutely be.
Okay, I'm sorry. My second part to this question is, how about if they are a non-English speaking client?
We use interpreters all the time. We use local interpreters. We're also doing a lot more with Interpreter International. So we try to find people that can help us translate and be that person in between.
Do you give them a list of agencies that speak different languages and speak their languages, or you just give them the same list?
Everybody gets the same list.
Okay.
There is a category about what languages they do, have, but everybody gets the same list. We're not going to give person A a shorter list than person B.
Okay, I have a question. This is maybe as much for Stephanie as you, Laura, but if somebody's turning 65 and they're on Medicaid waiver, Stephanie, I don't know if you want to jump in on that one, but what do they need to do?
Well, I think that Laura touched a little bit, and I'll let her touch on whether they should be working with the League of Human Dignity or NOA, or what organization they might be, what change that might result in. But one thing is, if they're turning 65, some of their choices change related to their insurance that they have. So they may be eligible for a Medicare supplement where before they were not. So if they're part of any spend down program, they may look at making a change to that, because with a Medicare supplement, it removes some of the barriers when it comes to networks. And so that's one thing I think that one of the main changes that I see in those types of situations. And Laura might want to touch on which agency they're working with on when it comes to waiver.
Anymore, they have a right to choose. So I encourage people to call NOA, ask questions, call us, ask questions, and make a decision. It really doesn't matter. I mean, we are really focused on person-centered planning. We are really focused on a person's choice. And we have people all the time that choose us over NOA that are 65 and older. Sometimes there's a group of individuals that want to keep Meals on Wheels, which NOA does. And that becomes a conflict of interest for them, keeping that person as their service coordinator, as their service coordination. So they have to choose us if they want to keep Meals on Wheels.
I've got one here that's maybe more for Vicki, but for both of you. So if Medicare pays for skilled therapy, does it, what happens if Medicare says, hey, we're done with the therapy thing? So Vicki, you want to hit that one?
Yeah, so typically, if a client is eligible for the waiver, we know that they're eligible for Medicaid. When we come in from a skilled therapy standpoint, we would be billing their medical-based benefit, of whether that be Medicare or Medicaid. So it should not conflict at all with the eligibility or the services that are being offered or qualified under the Medicaid waiver, as far as I understand. Is that true, Laura?
Yes.
Yeah. So they really come out of two separate coffers or two separate domains of payment and funding.
Right. And did I answer the question on if someone is assessed and determined not to qualify, there an appeal process? Yes, there is. And you'll get a letter and you're able to appeal that. And it's adjudicated by the Department of Health and Human Services.
Laura, can you look up the line a little bit on the chat? There was a question about equipment, which actually I have a bias to wanting to hear your answer to. I didn't ask it. Nathan did, about if a client had been through medical-based services, had applied for durable medical equipment and had, through the medical funding, been denied that. I think if Nathan's still on, please, I want to make sure I'm interpreting that correctly. Would there be a avenue to pursue that equipment under one of these waivers?
Not that I'm aware of. The only thing that the league can offer individuals through our independent living site, and it's not major stuff, but if you need a manual wheelchair, a knee scooter, a walker, a rollator, a cane, bath chair, toilet riser, we have them really inexpensively. Most of that stuff, not all of it, most of it is $5. And we're happy to do that for you. We don't take big medical, we don't take beds, we don't take power chairs anymore. We have some bed railings, those kinds of things. Just call our office and they can get you to a level of care specialist who can help you with that as well.
And that is equipment that can be loaned out or checked out without qualifying for a waiver as well, correct?
Absolutely. Anybody.
Yeah,
yep.
That's a great community resource to highlight. Yes. Thank you.
So Laura, Stephanie made me jump on this, but I want to hear your answer, Laura, on this one. So if somebody has some income issues, if they're below 65, they just have too much income or whatever, what do you do in that situation?
Well, some of those, we do have some people that are in that boat, and there is a copay. And so they're responsible then to pay a certain percentage to their care provider. And then once they meet their, let's say it's $500 a month that they're going to have to share and cost share, they pay that first, then Medicaid will pick up, or then Waiver will pick up the rest.
Stephanie, you want to add anything, or so I know you're running that too, but.
Yeah, so just kind of depends on what their income is. Sometimes if they have health insurance policies that they're paying for, or if they're just a little bit over the limit, sometimes they can add a health insurance policy that might actually help them qualify for Medicaid, which then would make them, if they're eligible for waiver, then that takes care of any share of costs that they might have to kick in.
Laura, this is Marianne from Manoa. Will you do a level of care assessment on someone if they have just applied for Medicaid and do not have it yet, have not been approved for Medicaid?
Yes, we have in the past, yes.
But typically, is it your preference to only do those for people who are on Medicaid?
Preferably, yes.
Yeah.
But if we're pretty sure they're going to qualify, if we're, the whole 9 yards, then yes, we have done a dual process for individuals.
Okay.
Good question.
All right. Well, we're kind of up against the clock here. So first of all, just a huge shout out to Bev Ann for organizing this. And Laura, thank you so much for taking the time to join us. And I want to thank all the rest of the other panelists for being on this too. It's a lot of fun working with you guys. We have another one coming up in March. I believe we're doing it on some examples, particularly spousal impoverishment. What happens if you have one spouse that needs to go on Medicaid and the other spouse doesn't have a ton of money? How do you make sure that they qualify as efficiently as possible?
Okay.
Thank you.
Thank you all.